Fabulous. Again, thank you for being with us today for our PFCC Partners Community of Practice, our September workshop. This is who PFCC Partners is. Lindsay, if you go to the next slide, thank you. We are recording, and this will be added to our PFCC Partners YouTube channel. If you have not already subscribed, please subscribe and join us. We will have a live transcript, and you can hit the closed caption as well. This is who we are, who PFCC Partners is, and what we're all about. We are um, here to center the inclusive human experience of health. We're looking to reinvent through radical collaboration. So we're so glad that you're here with us. We have a vision to seeing a health system transformed, one that works with people and through communities as a partner in their well-being. If you go to the next slide. So we all know that healthcare is complex, it's difficult to navigate, and even more difficult to change. And that's why having these conversations together and partnering together is so important. So we're not reinventing the wheel, but where we can learn from one another. You go to the next slide. So PFCC Partners, we open a space within the system for patients and family caregivers to drive improvements. We are a team that all come to this space with lived experience, and we're working to create that space where other patients and family partners come to the table and improve the healthcare system. We'll go to the next slide. We do that through the PFA network. This is a network that was built by patient family partners for patient family partners. The PFA network is built of over 1,100 patient and family partners across the country. And the network fills the space with not only impactful people and stories, but also insights. We go to the next one. Next slide, please. And with that, I have the privilege of turning it over to Lindsay as we get ready to dive into our session today, asking for a friend and talking about engaging patient family partners and patient safety. Lindsay?
Awesome. Thank you, Naomi. And hi, everyone. It's great to be with you on the last Friday of September and the first Friday of fall, maybe? That might be right. Crazy, this month has flown by. But I'm so happy you've all taken the time to hang out with us a little bit today. As Naomi said, this is a little bit of a different format for our regular community of practice workshops. Um, we're really looking to build a learning community, and this month really focused on engaging patient family partners in patient safety. So, what we'd really like to do today is create a safe space to ask any questions that you have been holding back about engaging people with lived experience in patient safety initiatives or programs. So I know all of you, have responded to the questions on the registration. So we're really hoping to address that in a asking for a friend type of way. This concept actually came from another project that we're on with National Consumer Scholars. And they wanted to create a space for people with lived experience to ask the not so silly questions, the questions that probably all of us have, but aren't willing to speak up about. So I kind of stole that idea, and we're running with it here today. So appreciate all of you, bringing forward some of those challenges that you've been experiencing around engaging people with lived experience and safety. And I just want you to know too, We don't have all the answers here at PFCC Partners. Again, just looking to build this learning community. So, really creating the space for all of you to share what you know works really well, also. So, feel free to speak up and share throughout our time together today. We are going to start off with a little level setting content just so we're all kicking off on the same page. I guess I should introduce myself for those who don't know me. I'm Lindsay Galley. I'm the Vice President of Programs at PFCC Partners. And yeah, deliver a lot of our programming and helping hospitals, health systems, researchers, quality improvement teams to engage people with lived experience into the work that they are already doing, because this isn't new work. It's just a new way to do the work that you're doing. And I am joined by Libby Hoy, founder and CEO of PFCC Partners. So, Libby, before we get started, would you like to say hello?
Hi, everyone. Thank you so much for taking the time to join us today, and I look forward to the discussion and learning alongside with you. I think patients and families have really critical insights for our patient safety initiatives. And so, ensuring that organizations feel safe and feel, positive about building productive partnerships with their patients and families to address patient safety it's kind of a delicate topic, I'll be frank. So that's why we wanted to bring this format forward and really, create a safe space for learning about this. So thanks for joining us.
Absolutely. Yeah. Thank you, Libby. And thanks to everyone who introduced themselves in the chat too and shared, what makes them feel safe as well. And so we're talking about safety for a variety of reasons, but one of them is because on September 17th, it was World Patient Safety Day. So I'd like to share this quick 3-minute video just to give you a little bit more about World Patient Safety Day. This is from the World Health Organization and their focus for World Patient Safety Day this year. Give me just a moment. And it might start in the middle because I've watched it a few times. Yep.
Share concerns, ask questions. Every child deserves safe, quality healthcare from the very start. But for many newborns and young children, a hospital visit can carry risks that no child should face. We're looking at why and what we can all do to help. Children aren't small adults. They face unique health challenges, making them especially vulnerable to medical errors. Even small mistakes can have lifelong or devastating consequences. Meet Amya, a playful and curious 6-year-old. When Amya seeks healthcare, we need to look beyond symptoms. We must consider her development. Her mind, body, and needs are changing fast. Even something as simple as her age and weight can affect what safe care looks like. Amya also experiences health differently. Children don't get sick like adults do. The signs can be subtle and easy to miss. Amya depends on others, teachers, caregivers, and health workers to respond when something is wrong, to speak up, and to guide the way. And then there's the world around Amya. Living conditions like low income, language barriers, or limited access to services can make safe care harder to reach. To keep Amya safe, care must be tailored. Care that sees Amya as a whole person, adapts to her development, medical needs, ability to communicate, and living conditions. There are simple ways you can help. Let's say you're one of Amya's caregivers, visiting a clinic or hospital. Your role is to be involved and informed. Share concerns, ask questions, and take part in care decisions. You know your child best, so take an active role in their care. Now, let's say you are Amya's doctor or nurse. Your role is to be alert for the main causes of harm, such as incorrect medication doses or misdiagnoses. Start by building strong partnerships with colleagues and families. A collaborative approach identifies risks early and delivers child-centered care. Amia has a role to play too. Participate and speak up. We need children to feel safe and empowered to use their voice. It's essential for children to confidently share their name, describe how they're feeling, and ask questions. When everybody steps up, we can reduce risks and prevent harm. We can protect the next generation like Amia and work towards safe care for every newborn and every child, right from the very start. Share concerns.
Sorry. So I just really liked that video. I feel like it just creates a community around safety. And I think in order for us to be able to have those programs and policies in place where there is collaboration, it starts from engaging people with lived experience and Amia and her family and creating those programs and policies as well, which is what we're going to talk about more today. But I'm going to pass it to Libby to talk about another reason we're talking about patient safety today.
Thanks, Lindsay. Yeah, there's a lot of drivers for why we're really focused on engaging patients and families into safety improvement. And that video is a great, kind of level setter. Another driver in the environment right now is the patient safety structural measure, which hospitals specifically are tasked with attesting to a number of elements that they have in place in order to meet the patient safety structural measure. And I guess, this isn't a webinar about PSSM. It's really about acknowledging there's a lot of drivers out in the environment for engaging patients and families into your patient safety. And it can really feel like a long road with no end in sight. And in a way, I suppose it is. And I want to acknowledge that, patient safety is a never-ending focus. It should always be our focus. It should be part of the environment on a daily basis. And I hope that by the end of today's session, organizations will feel liberated to think about patient safety as the organization's responsibility entirely, because patients and families have, as I said, critical insights that can really help us to meet the goals that we have in patient safety. And so what we're going to really dig into today is how do we build the structures for meaningful partnerships so that the organization gets the information they need and ultimately we improve outcomes together. So on the next slide, for those of you who have seen the PSSM, the fifth domain is patient-family engagement. And in those, sweet little colored boxes is a lot of work. There's a lot of tasks within this domain that organizations are set to attest to. What I really want to encourage us to think of, though, is if we're setting up a robust method for ongoing engagement of patient-family partners in our patient safety work, these are going to get taken care of. So let's focus on really integrating patient engagement into our organizations, in our patient safety initiatives, and let the details take care of themselves. And so that's really kind of our focus for today is how do we engage in these specific activities, but also on a more holistic front so that the organization benefits from their patients and families as partner to build a safer culture. All right, so on the next slide, this also isn't a session about the ACT framework, but I would be remiss without mentioning this and dropping in a link to the ACT framework for those of you who are interested. So this is a distributed model that I have to say came out of a human-centered design process with patients and family partners, with health system staff, frontline staff, state hospital association staff, all having some input on, what are the advisory councils of today and what could they possibly look like in the future? I will admit that as we were starting to think about this, the PSSM came out and we thought, gosh, it's going to be really tough to meet all of those attestations in this traditional framework. We need to use this framework and branch it out to really be able to meet all of those requirements. So the ACT framework was created to solve three major problems in advisory councils. One, the lack of diversity. I think a lot of patient family advisory councils are made up of members that look a lot like me, and that's not necessarily representative of the population. I'll take responsibility and say, with every PFAC we've ever built, we've said, you need to represent the population that you serve. And then we've sort of walked away and never really gave them an opportunity. The ACT framework gives a no wrong door to engagement that ultimately transforms and develops the diversity that you are looking for. We know this because we do it with our PFA network ourselves. Secondly, limited impact of PFACs. Well, sometimes they get siloed in organizations, most often in the patient experience realm. And so this opportunity to inform and drive patient safety sometimes gets lost. So the ACT framework addresses that. And then finally, and I know this, our healthcare partners on the call will appreciate, to reduce the burden at our health systems, at our hospitals, our rural communities, our ambulatory care and primary care practices, reducing the burden of what engagement is, in order that these partnerships then become very powerful and very impactful to the organization. All right, so on the next slide, central to the ACT framework are lanes of engagement, and that's really what I want to dig into today with all of you. The lanes of engagement are, the concept is that there are multiple doors for patients and families to inform your patient safety work. It doesn't have to be in just one meeting. Rather, we can think about it in terms of, where are we on our patient safety journey? Are we at the information gathering? At PFCC Partners, we added an L to PDSA. We listen first and then PDSA. So what do you not know about this patient safety issue from the patient perspective? So can you use surveys, interviews, focus groups? On our registration, many of you mentioned as a priority for your organization preventing harms. So can you have a listening session with a group about a group from your organization who experienced falls, per se, and just figure out what you don't know? Ask what they know, what they can see in your organization in terms of unseen opportunities to avoid falls, and bring that forward. So bringing in the information seeking first, and then moving into human-centered design or co-design activities where you're engaging. Maybe you take a couple of those listening session folks and you engage them in a quality or safety initiative team and have that ongoing feed of the patient perspective. So each of these lanes is unique, but some are information gathering, others are co-design. And you can pick and choose which ones make sense within your particular priority. Another big priority that came through on the registration was education and awareness. Engaging patients and family advisors or partners to design materials at the outset is super important. Even further upstream than that is finding out, is that really an education gap, or is there something else going on that's producing what looks like a knowledge deficit? Then you can host a focus group to dive deeper into the topic and really identify what gaps in knowledge need to be filled, so that nobody has time to design things that aren't going to be effective. Bringing in the patient family partner early ensures that you're meeting the need of your community. Another priority was engaging special populations. And I was reminded of a situation where an organization set about to interview a person with diabetes who brought in their own food to the hospital. So I hear that being a common concern with inpatient hospitalization. Why are they doing that? And what is that's missing in the environment, so that then informs a systems change, or at least the opportunity to test your systems to ensure they're working in the way that you think they are. So that's just a couple of highlights in terms of what your priorities are in different ways to engage beyond a PFAC. PFACs are fantastic, and I think they can be important structural sort of gatekeepers for all of the other engagement activities. But if you don't have the resources to do that right now, it doesn't mean you can't engage patients in your patient safety efforts. All right, so that's a bit of our level setting. And with that, I'm going to turn it back to Lindsay. So thank you again for registering and giving us so much of the information and the questions that you all had. We're going to respond to that now and just invite all of you into the discussion. What are your questions? What are your solutions? Let's learn together so that we can advance patient safety, because aside from the PSM, aside from any Medicaid requirements, aside from any federal requirements, it's the right thing to do. And it's why we all come to work every day together. So let's lean into that and create the learning. Lindsay, you want to start us off?
Yes, absolutely. Thank you, Libby.
Mm-hmm.
So in this first section, we'll be addressing some of the questions that came up around specifically engaging patient-family partners in patient safety projects. So we've gathered some themes. The first being recruitment and participation barriers. And recruitment is a big lift, especially for advisory councils. We've helped a lot of hospitals and health systems in developing their patient family advisory councils. And we say recruitment never ends. It takes a lot of time and resources. So, we have some themes here: engaging when volunteers are scarce, limited resources. What we really focus on is some of those non-traditional engagement approaches, like Libby had shared, that directly impact your organization's strategic priorities. So we find when we have like a really specific focus. So if it's around safety, like maybe your organization or your hospital really has an issue with falls, you can recruit to a listening session focused on that and recruit patients who have an experience of falling or were a fall risk in your hospital. And that you can directly engage them into an activity. So we find it's a lot easier to recruit to something really specific rather than a broad, idea of a patient family advisory council. But that's not to say that that listening session might turn into building, future relationships and more relationships that can turn it into something more formal, like a patient family advisory council. So I'm going to stop and see, is there anything else coming up for anyone, or things that you have tried that worked when it comes to recruitment or participation barriers that you've identified?
Hi, Lindsay.
Hi, Peter.
How are you?
Wonderful. Great to see you here.
Great to see you as well. I have a few thoughts if you're open to me sharing them, particularly
I
about
am.
recruitment. And I think, hi everybody, my name's Peter. I work for an organization called the California Quality Collaborative. And we work with a lot of different organizations here in California throughout the delivery system. And part of what we do with the support of the PFCC Partners team is engage patients to try to understand a problem before we solve it. And I think Libby, Lindsay, Naomi, you've set that up for us this afternoon very well. I think when we think about recruitment, I absolutely agree, Lindsay. It's the most intensive, time-consuming kind of aspect of this work. But I think part of that is because it's really important to bring together a very diverse representative group of individuals who are impacted by the question that you're looking to gain some insights for. To help us do that, and in our recruitment efforts in the past, we've really sought to lean into trusted partners. And those trusted partners may be the hospital system, the hospital. They may not be, though. They may be other community organizations that have an affiliation with the hospital. They may be a health plan. They may be a community resource center. They may be a church or another religious type of organization where we know patients who are coming into our delivery system have interactions in those settings. So leaning into those relationships really to spread the word, right, and getting those that information into as many places, many venues that we know our patients will interact. Uh, to try and just get folks eyeballs on information, really, and creating that spark and that engagement. And I think I love you shared, Lindsay, about it may build and become something more. And then it's that first interaction that helps us kind of build a future path that we might not actually know yet. So
Right. That's so true, Peter. And I know with the project that we worked on with you for Equip LA, we started with a listening session and then had the opportunity to engage a person with lived experiences in those working groups, all throughout the project. So I think, and with that listening session, casting that huge wide net, which is exactly what you're talking about, and leaning on those trusted partners to help you, I think that really speaks to, yeah, addressing some of those barriers. Thank you.
thanks.
Lindsay, I can add in. Yeah. Oh, go ahead.
No, go ahead.
Then, so I'll keep going. I can add in just from the experience that we had I'm Kim Workmeister with Convergence Health. The experience that we had in trying to engage patient and family voices who were part of this giant national program. We were so fortunate to be able to tap into the PFA network, also into we were able to design a group that was representative of the areas of the country where we were working in too, but all on a virtual basis. I think being able to have a virtual participation was really key for that too, but also I think I've told this story a few times, just being able to be humble, my own self, being able to be humble and sit back. And even though we're working on something patient safety related, where I've been a nurse for 32 years at this point, I've been working in quality and patient safety for 25 years. There is so much that I don't know. And it wasn't until I was able to say, all right, guys, I don't know. You tell me what we could do, and just leaving the floor open for, no bad idea, no invalid thought or idea to come through. And we were able to do some really cool things that actually did advance improved outcomes for the patients that we were serving. So that's a little bit there. I think just being humble on the side, if you're on the side trying to gain engagement and interaction with patients and families, has been a real eye-opener for me.
I really like that. Yeah, that humility, but you also spoke to like the flexibility for participation too. I think that is huge, like having multiple ways for people to participate
Yes.
in something. And I know throughout that project, we had the virtual meetings, which I think leaves space for so many more people to be able to participate in those conversations, but also like the countless number of surveys and listening sessions, and that all just fed into this community, speaking again to those non-traditional approaches. Awesome. All right. I'm going to move us on now to another theme around training and preparation, which is so important, especially for a new patient family partner, joining a safety committee. I think there's a lot that really needs to go into their preparation around, who is on the committee, why are they there? I was just on a session where we talked about this, why are people in the room? What is my role as a patient family partner? What are our goals? They need to have all of the same information that staff has as well to be a really effective and impactful partner on, any type of engagement opportunity. And Libby, I wanted to ask you, because we talked about this, we're starting to talk about patient safety with our LA County Health Services Patient Family Partnership Hub. And I wasn't sure how to address like harm events, or like inform them that harms do take places or take place in hospitals and health centers. So addressing that, and I know we talked a little about that, Libby, but I wanted to get your 2 cents there.
Yeah, I think the, way or the path forward with that, and understandably, the health system is concerned about that conversation, and a lot of health systems are concerned about that conversation. I think the path forward on that is to sort of disarm patient safety, not as focused on harm, but as focused on preventing harm and leaning into, we have a lot of information about the culture of safety and what does a culture of safety look like. And so really leaning on those aspects as sort of initial points, I think is a really great way to go. I think that we really need to hear from our health systems. What are the fears around patient safety, and how can we think together about how we solve some of those? So, a big one is privacy, of course. If you're going to be sensitive and discussing patient safety data, I think that that's a reasonable request. What are some of those on the call doing about those concerns? Are you covered by a confidentiality agreement? We use a memorandum of understanding with LA County DHS. Um, you know, what kinds of safeguards are you thinking about as you move this forward?
Hey, Libby, uh,
Yes.
Roger here.
Oh, hi, Roger.
I sit on a board of directors for our local community health center,
Mm.
and I'm part of their safety group and their performance improvement. Um, and when you have sentinel events and stuff like that, you know, the only thing that we see is what has happened. There's no names, there's no, identifying characteristics. Um, the staff makes sure that HIPAA concerns are always addressed. But when you join a group or you join a committee like that, you have to be understanding that what you hear here, stays here.
Yeah.
You don't spread names, you don't do stuff like that. So it's about trusting and being true to it. Um, and so I think having people wanting to join these committees and asking, can I join this committee? Can I be part of this? Teach me, let me know what I can do. It's just asking the questions. And there's, like I've said before, there's never a stupid question. And you'll find that when you ask these questions, there's people around there that are going to say, I was wanted to ask that question. But you said it first.
Exactly.
So true.
It's being meaningfully involved in it also, you want to be part of it. You want to be, open and honest and meaningful. But it's when it comes to safety events and sentinel events, it's really it's just the outlines of what's going on. But they do report every month on what happens, and they ask for feedback and from the people on the board, and um, yeah, sorry.
No, no, I really appreciate your
Right.
thoughts, Roger. And I know you've been doing this work for a long time. And you bring up some really good points that we saw a lot of in the registration. HIPAA was everywhere, right? Everybody's concerned about HIPAA, and thankfully, right? It's put there for a reason. And so I think, just as you said, when reporting to and engaging patients and family partners into patient safety, and thinking about de-identifying information and all of that around the event, I think that that and being concerned about HIPAA in that regard is super important. And I think, most of our health systems are really keyed into that. I think where it gets a little bit muddy for some folks is how does or does HIPAA impact the role of a patient family partner? So when I or Roger are sitting on a patient safety committee, is the information I'm sharing from my own perspective um, relevant to HIPAA? And my understanding and our operations is that it is not. I choose whether I come to share my perspective. I choose my story. I own it, and I can share that in the benefit for the benefit of a patient safety initiative. So, really important to distinguish between HIPAA as it relates to the clinical encounter and HIPAA as it relates to the patient-family partnership relationship.
Mhm. Absolutely. Great discussion. Thank you both.
Mhm. Any comments on that? Does that feel comfortable for people, or are people unnerved? Usually I see a lot of shoulders go up when I say that. Oh, thanks, Lori. Your family's signed a confidentiality agreement. Overall, we don't use HIPAA during the telling of the story. Mhm. That's key to it, right? Building trust is if your family advisors are sharing their stories, that you let them know who's in the room, let them know, sort of the desired outcomes of that meeting. So I think in those activities really build trust.
Um, Libby, I wanted to add a couple of thoughts, and I'm kind of resonating with what I'm seeing and coming through the chat. I think it's really important to set and establish sort of expectations for a group and boundaries about what is and is not appropriate. And those may be formalized, and I think we're seeing examples of formalizing that, but also informally in a conversation. I think about, many of these meetings are virtual these days. We have the opportunity to record them. Are we going to record them? And are we going to tell folks we're going to record them? And what happens to the recording? I think I forget who did it from the PFC Partners team, but you shared that you were going to record it and it was going to be posted to YouTube. I think those are great examples and things we can bring into these spaces where we're engaging patients, at best setting expectations before we enter the space. And I think building safety and trust through that approach. The other thing I'll call out is AI is everywhere these days. And establishing a policy about, well, what if somebody brings an AI note taker into a room? What do we want to do with that? Do we want to turn it off? Do we want to leave it on? What happens with that information once we leave the room? So I think these are just all things that we can contemplate as we come together and set expectations, boundaries for the group, and what happens during the meeting and then after the meeting in terms of sharing and disclosing information.
I think, Libby, I think when you said it, we choose to share what we want to share. I choose to, tell everybody I'm HIV positive and I've been for 32 years. I choose that because I know in doing that, it's helping somebody else. So there's levels of commitments and levels of, what you want to share. And it's so when it comes to HIPAA and stuff like that.
Absolutely. And I'll just say, Peter and Roger, you're just speaking to the power of a partnership, because Peter's talking about putting in the infrastructure, setting the expectations up front, to really have a productive partnership. And Roger, you're bringing the passion and knowledge and lived experience that others need to hear. And I think when we kind of look at it as this holistic approach, rather than trying to meet measures or this mandate or that mandate, then we really start to benefit. Our patient safety outcomes really start to benefit. But really very cool.
So true. Yeah. What a great discussion, and important, especially because that did come up a lot in the registration too. So I appreciate that conversation. And we could probably keep talking about it, but we got a lot of other themes.
I know. I
want to answer everyone's questions. So yeah, I moved just a few more themes forward here, which essentially kind of go together too when it comes to representation and inclusion and building trust. We talk a lot about being a trustworthy organization, or being trustworthy rather than building that trust among, people with lived experience. And you can do that in so many ways. I think the easiest is to listen, and listen empathetically, and listen to understand rather than try to fix everything, because unfortunately we can't fix everything. We have had the honor and opportunity to have conversations in LA County with immigrant communities who are feeling the impact of anti-immigrant policies. And I'm always just so amazed by how open they are. But I do feel like we are so honest with the things that we have control over and the things that we can't. And so we really just provide the space for people to share and listen without jumping to try to fix everything, because there are things that we can't fix. But being honest about that, and then doing what we say we're going to do. Also, if we say we're going to give you resources, we're going to give you that, in a timely manner. If we say we hear you on this topic and we're going to share this with leadership and see what changes are implemented, and close that communication loop. I think that's the biggest way to represent a trustworthy organization, as well as to really close that communication loop and let people know that we hear what you said and this is what we did. Any other just thoughts on what's coming up here? I don't know, for some reason, how to convince patients to want to partner is an interesting way to put that as well, because I don't think we can convince patients to want to partner. That's why when it comes to recruitment, we cast such a wide net. We work with trusted partners and we identify people who have intrinsic internal motivation to want to partner. I always tell this story of the woman. She was in a heart failure support group, which terrible term for that. I'm sorry. But that's what it was called at the time. And she found this opportunity because she had experienced ICU delirium. And she saw this opportunity to join a group focused on ICU liberation. And she just saw it and said, oh my gosh, this is for me. But you're not going to find those people by passively, recruiting. It's finding those trusted partners, going to places where the people you want to engage are, to identify those who are jumping at the bit to share their experiences and help improve care for other patients and family caregivers. Anything else coming up there for anyone? Yeah, go ahead.
I was just going to add, yeah, I think, 5-6 years ago, we had maybe 100 people in the PFA network, and now we have over 1,100. And there's a lot of people eager out there to partner and to do this work with you. So, yep, avoid making any assumptions.
Absolutely. Yeah, go ahead, Kim.
So the representation and inclusion part is really resonating with me. In addition to the work that I do with Convergence, I'm the chair of the PFAC for our local trauma center, and there was the person, she actually leads up all of their interpretive services, and she had identified that there was this issue with outcomes for patients who were Spanish speaking that were different from outcomes for patients who were English speaking in the hospital. And she, when it comes to our PFAC there, well, I'm the youngest person on the PFAC at age 55, and I'm the only one who's still working. Everyone else is retired, and they all look exactly like me, and they all speak English. And I was so thrilled to see that, rather than just sticking with the traditional, we're just going to go to the PFAC at our once a month meeting. She really took things in a completely different direction and started actively looking for Spanish speaking patients who had been in the hospital in the past for these focus groups. And she used Spanish speakers to reach out to them. And the conversations were only in Spanish. And she got to be able, she was able to really build trust in this by, with again, ensuring that it wasn't just a translator that was talking to them, it was someone who was actually speaking in their native language, and talking about how we, as a hospital, really wanted to learn more about this. And it was such a neat experience to see this. And they've now taken this to, a whole bunch of other places there too, where it didn't even require our official PFAC to be engaged, because they knew that we weren't the right people. And gosh, we learned so much from that. I've been able to make massive changes at the hospital level that we wouldn't have done if we'd stuck with just our traditional approach too. So I guess just to encourage folks that even if you have something active in place, that still might not be the right group or the right way to engage the patients and families who need to be at the table, whose voices really need to be heard.
Right. Two things can be true at the same time. And you're again, yeah, speaking to those non-traditional, engagement approaches that serve different purposes, and that's good. That's like we'd love to see more and more of that, but also using data, identifying, what do we need to improve, and then actively recruiting for the individuals who we need to hear from to help us improve that specific um, challenge. So we know that example and we promoted it a lot. And yeah, absolutely. All right. We have one more section of themes around gaps identified to improve engagement, but wanted to really quickly touch on sustainability and resources. We know that resources are limited among, our health systems and hospitals, but more so focused on staff buy-in and leadership support. We have found that taking the listen PDSA cycle and applying that to engagement works wonders. So doing small tests of engagement and getting those small wins, having small impacts so you can go back to staff and you can go back to leadership and say, look at what we did over here. Look at the impact that we had. Look at the data that we changed, because a lot of the time staff and leadership, it's hard to see something that you haven't been able to see yet. So having, data and that quote unquote return on investment of engaging people with lived experience, I think taking those small steps can lead to, bigger and bigger outcomes. Libby, anything else to add there around the other?
Yeah, I think even when you're challenged to find impact, or maybe the data is going to be sluggish and changing, you can track and promote the information and the insights that you gained, and the way that maybe changed the direction of your patient safety initiative. So, it ensures, and this is something I think that resonates with leadership, is that it ensures that you are solving the right problem, right? Nobody has time to solve the wrong problem. So if we want to reduce readmissions after cardiac care, and we set about a patient education system, but the problem is really accessibility of medications at the local pharmacy, then we don't have the right information to be solving the right problem. And I think that just tracking what you're doing, tracking the information that you're gathering, and sharing that with leadership is a great way to say, this is the efficiency. This is how we're saving time, energy, resources, and finances, because we know we're solving the right problem, right? My friend and mentor and driver of all things patient family-centered care, Beverly, I see you have your hand up, and I'm so glad to see you.
Such a wonderful way to spend Friday afternoon after a long, hard week.
Oh, yeah.
You all are it's a fresh air, just terrific. And it helps me rethink. I love your idea of all the little ways to listen and to create listening opportunities as key important steps to enhancing safety. I'm grateful that we do have the CMS patient safety structural measure, but it worries me that people will think we've got the structure here and it's not real. It's in name only. And I think your idea of listening, I really want to think more about it, but the informal listening sessions as a way to connect on safety issues. I often, when I meet someone who might be interested in being an advisor, I ask them about what was helpful about their health experiences, what was not so helpful, and how would they improve it. And I always learn from those sessions.
Mm-hmm.
Two, I think it helps build their awareness that they have something to offer. Their perception is like gold in terms of really understanding the real situation And I think you build that informally and you grow your group to be effective in, as you said, Lindsay, you need a lot of preparation to be on the safety committee, but I think that's a way we can do it and bring more diverse people who may not understand all the complexity of how our hospitals function, and that they can actually make them better.
Well said, Beverly. I'm so grateful for your presence today and your sharing your
As a learner.
wisdom. We're all learners.
Yep. No, I really appreciate that. I'm glad that, yeah, that sparked some new ideas too. And hopefully we can continue conversations and sparking more and more of those. But yeah, I appreciate that. All right. Libby, I'm going to pass it to you. I don't know how you want to approach the next 8 minutes.
Well, we figured this would be a packed session, but
Yep.
let's go through kind of, why don't you just drop all of them in? So what we asked you about is any gaps in your engagement practice, like what are those areas you need help with? And I'm sorry that we left so little time for this important section, and maybe that moves us forward into a subsequent session. But we talked a little bit about stakeholder and leadership buy-in. I think just demonstrating again what you've learned, setting out sustainability practices from the beginning in terms of tracking how just the volume of hours and time that people have given you, I think is a compelling demonstration to leadership of the impact of patient-family engagement and safety. Patient-family understanding, absolutely imperative. We can't bring and expect patients to bring their lived experience in a way that's relevant and helpful to the patient safety initiative without giving them the context. Context is everything to me as an advisor. If I don't know why I'm in that meeting or what we're trying to achieve together, then it's really hard for me to make my experience relevant to what we're trying to work on together. And that's where I know a lot of organizations struggle with, gosh, our patient family partner is just stuck in their own experience. That often happens because we don't know what we're doing there. So where do we fall back to? What we know, which is our own experience, right? So sometimes that's a signal that more preparation is needed, more context is needed. We've talked a little bit about HIPAA and communication and transparency. And, I would say give yourselves grace as you move forward and be intentional about how you build yourself as a trustworthy source, whether that's you as an individual, your department, your organization, um, being consistent in your communication, being consistent in your follow through, being consistent in setting expectations and then meeting those expectations. I think all of those things are ways that you as an individual can build yourself to be a trustworthy person, and then your department and your organization. Resources and capacity. This is always going to be a problem, and I'm fearful of the immediate future and how that's going to be even more difficult. However, it's even more important that we engage this perspective so that we're not wasting time on things that are not the root of a problem, right? Data tells us what's happening. People tell us why. Staff tell us why. Patient family partners tell us why. So really, really important. Um, Best practices, strategies, and tips. This is the part I wanted to hear from all of you. And so let me just stop here for a quick second and say in the chat, if you would each put in one thing that is your best practice or strategy for engaging patients and families into your work. Not maybe it's not even patient safety work at this time, but one trick or strategy to share with this community. I'm going to give you just a minute or two to think about that and put it in. And we have a lot of patient family partners from our PFA network on today, I see. So I will also invite you to share what's one thing that helps you to be effective in the role of patient family partner. Oh, shoo, I thought nobody was going to answer. This is great. Embed PFA in all our monthly departmental meetings. Great, Jody. Sending out agenda in advance. Kim, I love being humble, and I don't know of anybody who exemplifies that more than you do. So maybe you can give us all a lesson in humility. Ah, Trish, I love that. Don't be afraid to recruit from a negative experience. Absolutely. When people take an opportunity to submit a grievance, in my mind, it always says they're doing that because they want to make sure it doesn't happen for the next family. That's a great place to start as a patient family partner. Wonderful. Recognizing the need to listen, having pre-meetings, Emily, prior to the team starting. Excellent. Yes, I knew this was a brilliant group. All right. I know we are super short on time, but I think it's important. Obviously, equity and representation, we have talked a lot about that, and it's difficult to get the perspectives of immigrant communities. I think it takes a long lead up ramp to be able to really connect with those individually. So I'll throw it back to Peter's suggestion of creating trust brokers in the community and folks that are working directly with those voices and bringing those in unique ways. Okay. Well, with our last couple of minutes here, I'm just going to go to the next slide. Um, Lindsay, I don't remember what the poll is. What's the question?
I can open that. I was
Okay.
just getting the link in the chat, but if you have a smartphone, you can hover over this and it'll take you to the poll. There you go, Libby.
Oh, I think, yes. Just wanted to find out, is this format helpful to all of you? Is this something that you would like to see more of from us? Thoughtful. Great. Thanks, Roger. Karen does not like QR codes. You can let us know in the chat.
You can put it in the chat too. Yep.
Yep.
We can capture that.
Anyone else can as well. Okay. We're always trying to improve our own ways of meeting the needs of the community. So this is really helpful to us. Thanks, Bobby. And yeah, as we said, if you don't have the opportunity to get to Slido, you're welcome just to drop that in the chat. Your rating, I think we have a second poll. Again, on this line of thinking, would you be interested in additional sessions like this? I think we can schedule them a little or plan them a little bit differently so that we get more of our colleague interaction. But I'm so excited to see 100%, but then I see that there's only been 2 people.
4 now.
Okay. So again, feel free to drop that in the chat as well.
Thank you, Karen.
All right. I think we can move forward. We've done that.
Enough of that.
I hope that we'll see some of you at Putting Care at the Center. If you haven't had a chance to register, I just got a message this morning. There's only 20 spots left. So if anyone, hopefully we'll see you. PFCC Partners will be there in full. And we have 4 sessions there. So I hope that if any of you are going or planning to go, that we'll definitely meet up. All right. And with that, thank you so much for joining us. I apologize for going a minute over, 2 minutes over, sorry. But thank you so much for participating in the conversation. It's always great to see you, and we'll see you again soon.